Hello, everyone. I'd like to start promptly at noon. We have the pleasure of hearing Dr. Leanne Hirano, who will be speaking to us on updates in delirium, a useful topic probably no matter which specialty or subspecialty you're in. To give you some information about Dr. Hirano, she attended college at Bowdoin. She went to medical school at the Yale University School of Medicine, where she studied with Dr. Sharon Inouye, who developed the CAM, the Confusion Assessment method. She did her thesis in delirium at Yale. She did her residency at the University of Washington and completed a geriatric fellowship here. Her career interest, long-term goal, is to become a physician scientist and work as a leader in improving care of older adults. The research that she's done in the past is to better understand the way in which diagnosis and treatment for male osteoporosis was conducted within the VA system in order to assure quality care is being provided to VA patients, minimize the risk of fractures and disability and healthcare costs they incur. She is currently conducting a study at VA Puget Sound to quantify the percentage of veterans at high risk for fractures who undergo bone densitometry by DEXA, evaluation for secondary causes of osteoporosis, and who are treated with calcium, vitamin D, and bisphosphonates as recommended by national clinical practice guidelines. She also plans to conduct a prospective randomized control trial focusing on men with prostate cancer who are started on androgen deprivation therapy. Currently, she's working on developing a clinical geriatrics program at Northwest Hospital. So, Dr. Hirano, thank you.
Hi, can everybody hear me okay?
Not well.
I don't think I expected such a big group because geriatric grand rounds is much smaller, but it's really an honor to be here, and I think, as Dr. Ron pointed out, my career has kind of gone around and taken me in very, very different places than I thought I would be. But I originally started off studying delirium with Dr. Inouye, and that's where I've always had a special passion for delirium in hospitalized elderly people. So this is kind of a presentation in sort of articles that have piqued my interest over the past year or year or two. I was actually really trying hard to figure out what I could possibly present to you all about delirium, because really psychiatry and psychiatrists are often the experts in delirium, and geriatricians kind of join you guys along for the ride. And more often than not, when patients become delirious on the medicine or surgical service, the psychiatry service is consulted to manage delirium. And at Northwest Hospital, where I work now, we actually don't have a geriatrics team, and so it's the geriatric psychiatrist who's consulted for delirium. So I decided to attempt to find some interesting trends in articles in the past year or two, again, that have caught my eye as a geriatrician. And I definitely want to invite questions and discussion, especially as we move into discussing delirium management in various settings in the hospital. And just to give you a little bit more background, I work 1 day a week on the Northwest Hospital inpatient service, internal medicine, and the rest of the week I'm kind of out at skilled nursing facilities in the community where I see a lot of delirium as well. And I think that's actually a nice setting for, that's rife with opportunity for delirium management. Okay. So I like to start off with a case. And this case was actually pulled from NPR Morning Edition in 2009. I occasionally like to listen to NPR, so hopefully they won't get cut in the national budget cuts along with PBS. Virginia Helton says her husband Earl, 79 years old, is a brilliant man. He's a scientist who can explain complex chemistry and physics, but when he was in the hospital last February, she didn't recognize the man acting so bizarrely, talking wild nonsense, taking off his clothes. So this story actually excited me because I figured, hey, delirium has finally kind of made primetime news. So to continue along with the story, this is Virginia Helton is his wife, And she says, I was feeling very scared. It was very disturbing to see him with all this confusion and disordered speech. So you can tell they're slightly more educated people. Delirium is a frightening experience for them. But overall, this kind of is a familiar story, I think, to most of us who do delirium consults. And Earl himself says, after he got through this, I remember quite vividly my desire to escape, and I was proposing all sorts of fantastic schemes, according to the kids, as to how I could get out and get out of the hospital. As a matter of fact, I ended up executing that on at least one occasion and managed to get through the hospital and underneath one of the surgical beds. And so his wife again says, they tied his hands down because he kept trying to get out of bed, and that made him furious. And they did that several times when he was in the state of delirium. And I think, again, this is quite familiar to a lot of us who get consulted on delirium. We see it in the hospital quite a bit, patients being tied down. I think all of you are very familiar with this, so I won't belabor this, but the DSM-4 diagnostic criteria for delirium, disturbance of consciousness, so clearly reduced clarity of awareness of the environment, reduced ability to focus, sustain or shift attention, a change in cognition, such as memory deficit, disorientation, language disturbance, or the development of perceptual disturbance that is not better accounted for by a pre-existing, established, or evolving dementia. And C, acuity. The disturbance develops over a short period of time, often differentiating it from dementia. And then there's evidence from the history, physical exam, or laboratory findings that the disturbance is caused by the direct physiological consequences of a general medical condition. And I think you guys are, yeah.
Because the audience is so full, the microphone's not functioning.
Oh, okay.
Could you take it off and hold it while you're speaking?
Oh, okay. Is this better? Okay, sorry about that. Thanks for pointing that out. Okay, so moving on, epidemiology. Again, I am sure this is something that a lot of you are familiar with. The prevalence of delirium at the time of admission has been found to be anywhere from 14 to 24% in studies. And the incidence of delirium developing during hospitalization, again, has widespread, anywhere from 6 to over half of patients, 56% developing delirium during their hospitalization. And then particularly apropos to the surgical services, 15 to 53% of older post-op patients developing delirium, which I think is a place that we frequently see it and a service which frequently consults us on delirium. As you're probably all aware as well, the reason why these percentages are such a widespread is because a lot of these studies were done in places where we're just beginning to figure out even how to recognize delirium accurately. So the human and financial costs of delirium are quite significant. Mortality rates among hospitalized patients with delirium can range from 22 to 76%. And I'm pulling these numbers from Dr. Sharon Inoue New England Journal article that was published in 2006. And it was an article on delirium in hospitalized elderly patients. The one-year mortality rate is 35 to 40%. And these rates are equivalent to heart attack, MI, and rates of sepsis mortality. So they're really quite significant. And we know that heart attacks and sepsis get a lot of press, and delirium, I think, is not quite getting its due yet. So other costs, delirious patients cost an extra $2,500 per hospitalization. Approximately $6.9 billion of Medicare costs annually. And these are numbers taken from 2004, so you can imagine today, with our increasing population of elderly, that these numbers are probably far larger, and the increase of hospitalization has also increased. So again, these numbers are going to be astronomical. And if we can prevent delirium, that obviously presents a great cost savings. Maybe we can save NPR and PBS. So, further costs. And these are kind of where we're moving into more of the updates and things that have been studied a little more recently. Mid-2000 to late 2000, several studies came out demonstrating that, again, delirium is costly. It results in longer hospitalization, longer length of stay, and on average it increases patients' length of stay in the hospital by 5 to 10 days. Patients are more likely to end up in a nursing home if they develop delirium, 16% of delirious patients versus 3% of patients who did not develop delirium. And delirium is associated with long-term cognitive impairment, and I think this is this was a very new finding near the end of 2000, where a lot of studies came out, or a few studies I should say, came out about the neurological costs of delirium. So another area where I felt that I was beginning to see a lot more articles, mainly from Dr. Wes Ely, who actually presented internal medicine grand rounds here last year, if any of you were able to catch him. He developed several studies looking at delirium, particularly in the ICU. So probably, let's see, he's really, I feel, led the charge on delirium in ICU, mainly in mechanically ventilated patients. And I think this is a population that I myself have not really suspected delirium in. And traditionally, I think a lot of physicians have not really looked to this population and really evaluated them well for delirium, because really in critical care we kind of sedate these patients and give them analgesia while they're on mechanical ventilation, and really we kind of expect them to be out of it and to be gorked while they're being mechanically ventilated, often using propofol, midazolam, fentanyl, drips to sedate them and keep them from trying to yank out tubes. But Wes Ely has really kind of turned this idea on its head, and I think it represents kind of a paradigm shift in pulmonary and critical care medicine. One of the first times I actually heard him talk was when I was a young, impressionable med student, and he was just starting out in his research into brain injury in the ICU. And I think what really grabbed me was he told this story of this woman who was an executive of a big company, and she had just recently undergone one of those online IQ tests. And shortly after that, she developed a community-acquired pneumonia. She was relatively healthy. She was in her late 40s, I believe, and really no significant chronic medical conditions, and ended up in the intensive care unit on the ventilator, and really not for a significant period of time, a couple days at most, requiring some ventilatory support. And she made it through her hospitalization, went back to her job as a high-functioning executive. And what she realized is, as she was working, there were problems and things that she could do easily prior to her stay in the ICU that were now significantly more difficult for her. And she couldn't really put her finger on the reasons why they were more difficult. It was just this overall sense of, gee, this was really easier for me to grasp before. I really could do these things a lot faster before my hospitalization. And she repeated her IQ test, and her IQ score had dropped by something pretty significant, like 30 points. I mean, it was pretty interesting. And so we don't, again, it's a case study because we don't all get IQ tests before patients end up in the ICU and are able to test them after. But I think Wes Ely has really developed some studies that are interesting and trying to measure the amount of deficit after patients are hospitalized in the intensive care unit. So this is a study that he conducted with Dr. Gerard, Delirium as a Predictor of Long-Term Cognitive Impairment in Survivors of Critical Illness, and this was performed in 2010. So their hypothesis, again, kind of based on this story that he told, is that the duration of delirium in the intensive care unit is an independent predictor of long-term cognitive impairment after critical illness requiring mechanical ventilation. So it was a nicely done study, a prospective cohort study of 126 mechanically ventilated ICU patients in a large community hospital in the U.S. The average age of these folks was about 61, so slightly younger, definitely than the population I deal with. But looked at mechanically ventilated patients, and they were assessed daily for delirium using the CAM-ICU, which was developed by Dr. Ely and validated in several studies as well. And then At 3 months and 12 months after their discharge, so after they survived this period of critical illness and were discharged from the hospital, they had comprehensive cognitive assessment. So results of the 126 patients they studied, 99 survived, greater than 3 months after their critical illness. So their long-term cognitive outcomes were obtained for 77 of the patients, so 78%. The median duration of delirium was actually pretty short. It was only 2 days. And age, education, pre-existing cognitive function, severity of illness, severe sepsis, and exposure to sedative medications were all adjusted for. So here are some of the results. And this is, let's see. So the way that they measured impairment, mild to moderate impairment, and severe impairment is they used this battery of cognitive testing. So the digit span and trail making test A to assess concentration and attention, the digit symbol coding to assess information processing, the Ray auditory verbal learning test to assess verbal memory, the Ray Osterreich complex figure to assess visual-spatial construction and delayed visual memory, trail making test B to assess executive functioning, verbal fluency to assess language, and of course the mini mental status exam. And then what they did was they converted all of these test scores into T-scores for standard deviation using age-specific and education-specific normative data. And the summary score of the cognitive performance, again, was calculated by averaging the T-scores of all 9 of the cognitive tests that they used. And this manner of measuring had also been previously used in several research studies, and so they were really trying to come up with a way of measuring that had been previously validated and to try to, if ever to be used in a meta-analysis, used in previous research. So mild to moderate impairment was designated if they had either 2 cognitive test scores 1.5 standard deviations below the mean, or 1 cognitive test score 2 standard deviations below the mean. And then severe cognitive impairment was defined as 3 or more cognitive test scores 1.5 standard deviations below the mean, or 2 or more cognitive test scores 2 standard deviations below the mean. And as you can see, it's pretty shocking, well, I would say shocking data, that over half of the patients at 3 months still had severe impairment. And these are people who, of course, they did not do this battery of tests prior to their hospitalization, but per family history, these patients had no previous cognitive impairment per their medical charts or their family history. And then at 12 months, a third of them still had severe impairment. So I think, the human costs here and the neurological costs are pretty significant that Dr. Ely and Dr. Gerard found in this study. So moving forward from there, why was this cognitive impairment happening, and what can we do to prevent delirium in the ICU? Delirium is what's causing this lasting cognitive impairment. So several things that they're now studying, and some studies that also came out around this time that Dr. Ely and his colleagues have been involved in, is Desmedetomidine versus kind of our more traditional drips in the ICU, lorazepam and midazolam for sedation for mechanically ventilated patients. So I think Desmedetomidine is kind of the drug of the future as far as ICU sedation, as far as these groups are kind of concerned. So one of the trials that they conducted was the MENS trial. It's maximizing efficacy of targeted sedation and reducing neurological dysfunction. And this was a 2-center, double-blind, randomized control trial of 106 mechanically ventilated patients. And they were randomized to sedation with either the dexmedetomidine or lorazepam. And this was a study published in JAMA in 2007. And they found that the dex group had more days without delirium, so 7 days versus 3 days. And and had a lower 28-day mortality, so 17% versus 27%, and survived longer in the following 12 months, so 363 days versus 188 days in the control group. Another study by Riker, which also came out in JAMA, published more recently in 2009, was Dex versus midazolam, which I see used frequently in our ICUs. And this is actually a really big study conducted at 68 centers in 5 different countries over the course of 2005 to 2007. And similar to the other study, the Dex group experienced less delirium than the midazolam group, so a rate of 54% versus 76.6%. So those, I know Dr. Ely definitely promotes Dex when he goes around and gives his speeches. Another thing that he also touts is early mobilization, and this one was actually kind of interesting. So there was a Lancet article published in 2009 on early mobilization, and it was a 2-site trial of 104 sedated ICU patients, again on mechanical ventilation, and they were randomly assigned to either an early exercise program or kind of normal care, and where their attending kind of prescribes activity for them. And the intervention group received daily breaks in sedation or daily interruption of sedation with exercise. So the early mobilization group was found to be more likely to return to independent functional status after discharge than those in the control group. And they also had a shorter duration of delirium, 2 days versus 4 days. And the author who conducted this study postulated that the activity, when you engage in activity, physical activity, actually requires mental engagement as well, and that's one of the things that these patients benefited from. And really what limits us in mobilizing people in the ICU is more our perception, the caregiver's perception of these gravely ill patients being so gravely ill and frail and not being able to do exercise and do activity. And really what they found in this study is that grave illness was actually rarely a barrier to getting patients mobilized, and it was more our perception of what patients were actually able to do. So again, delirium in non-ICU hospitalized elderly patients. Moving on here. So those were the Wes Ely studies and Tim Gerard's studies that kind of made big headlines in the past year, and I'm going to transition now to delirium in non-ICU hospitalized elderly patients on the floor, and I think this is a population that a lot of us are much more familiar with. And here's where I'd like to really open this up to discussion, because I'm very interested in what you guys are doing to manage delirium when you're consulted, and if it's really significantly different from what we're doing as geriatricians. So it'll be a nice way for me to figure out if we're kind of doing the same things or doing different things. I suspect very similar things. But what do you guys use to diagnose delirium? Do you use any specific instruments? I know we often use the CAM, but is anybody out there using other tools that you particularly like? No? I think we often use our clinical judgment and not necessarily think of tools to use, but one of the tools that Dr. Sharon Inoue developed and which Wes Ely then modified for the ICU is the CAM, the Confusion Assessment Method. And in August of 2010, JAMA produced this really nice review of accuracy of bedside instruments in diagnosing delirium in adults. And they did a Medline and M-based search, and they identified 11 instruments with studies that matched their search criteria. And what they found was that the confusion assessment method really remains the most studied, widely used in both clinical and research, and well-validated standardized tool. And I think it's because it's been around for quite a while, over 10 years I think we're coming up on. Does everybody know what the CAM is? No? Okay. So let me see if I have a slide on that. Okay. So the confusion assessment method is an algorithm, and it's actually based on the cardinal elements of the DSM-4. So the features, the criteria for delirium involve these identification of features, and feature 1 is the acute and fluctuating onset of delirium, and feature number 2 is inattention, and so they really are kind of the two definitions used in the criteria for DSM-4. So the CAM requires that to diagnose delirium, a patient has both features 1, acute onset and fluctuating course, and feature 2, which is inattention, and either a third feature, disorganized thinking, or a fourth feature, altered level of consciousness. And so you have to have both features 1 and 2 and either feature 3 or 4 in order to diagnose delirium in a patient. And the CAM comes with a 95% sensitivity and a 95% specificity, and so I think this is actually pretty good tool to use. Let me find my place again. Okay. I somehow managed to go backwards quite a bit. Okay. So the reason why I think the CAM is also widely used is because it's brief. You can conduct the CAM in less than 30 seconds, and it's easy to use. So a lot of nursing staff and lay staff can also use the CAM. You don't necessarily need to be specifically trained in use of this tool. And it's been translated into 10 languages for which published articles are available for each language. So continuing with delirium in our non-ICU hospitalized elderly patients, I think one of the consults that we often see is actually for the management of agitated delirium. So not only do you have to identify the delirium, but then how do you manage this agitated, hyperactive delirium? I think I rarely ever get consulted on hypoactive delirium. Those are usually the quiet patients that the nurses are going to have here are easy to manage. And I think one of the problems that I've really run across in managing delirium is that this new elderly mortality black box warning for atypical antipsychotics that has been issued in 2005 by the FDA. And I don't know if any of you have run into this, but our patients and their families are really quite savvy nowadays, and once this news hit, it was shown on CNN, it was shown on MSNBC, there were stories that came to light, and I was actually in the room of a patient prescribing quetiapine when CNN was showing the story of how quetiapine, specifically quetiapine, has a black box warning of increased mortality in elderly patients with dementia. And of course, I was prescribing it to an agitated elderly patient with dementia. And their family members just looked at me and said, "Whoa, why are you giving my loved one this medication?" And so we really need to, I think, weigh the risks and benefits with family members. This gentleman, was climbing out of bed. He had a Foley. He had already pulled out 3 IVs, and the risk of causing harm to himself and harm to the staff. He was actually quite a robust elderly gentleman, versus the risks of this increase in mortality needed to be weighed. But the family did agree that at this point in time, it was the risk of this increased mortality was definitely secondary to the benefits of really getting the delirium, the agitation under control.
And this was about dementia, not delirium. The FDA, for all its problems, it wasn't even about the delirium.
Exactly. It was the use of atypical antipsychotics in elderly patients with dementia, and they didn't specify what the use was for. So it could be, elderly patients with schizophrenia, elderly patients with agitation for other reasons. But I think a lot of the time what we're using atypical antipsychotics for, at least as geriatricians, is management of agitated delirium. And I am specifically avoiding the word treatment because I think to treat delirium, you're treating the underlying causes, and really using atypical antipsychotics to treat delirium is a bit of misnomer. It's more to manage this agitated delirium that we see. So how did the FDA come to these conclusions? They did a meta-analysis of trials of aripiprazole, olanzapine, quetiapine, and risperidone, so many of the atypicals that we commonly use in agitated delirium. And they did this in patients with delirium and demonstrated 4.5% incidence of mortality in these patients treated with antipsychotics compared to 2.6% with placebo. And that's really what kind of put the nail in the coffin to get this black box warning. Appropriately so, because several studies have shown significantly higher mortality with atypical and typical antipsychotics. I should also mention that, if we think Haldol is any safer, which we initially did when the FDA produced this black box warning, it has since actually been shown to have significantly higher mortality than the atypicals. And this was shown in a retrospective cohort study, so not the best type of study, but it's there. So there have been several studies actually comparing atypicals versus typical antipsychotics for agitated delirium. And these are usually very small, randomized controlled trials. And small, I'm talking about n's less than 50, and they're usually retrospective. The good news is, though, that all of these small studies and retrospective studies actually are pretty consistent in their findings, and what they found is that atypicals are as efficacious as Haldol for hyperactive delirium. And they've also found that atypicals have a lower rate of extrapyramidal symptoms, but overall both atypicals and typicals have an increased risk of cardiovascular and cerebrovascular adverse events. It's also been shown to have an increase in the rate of pneumonia in these patients as well, but it's really the increased rate of mortality that has caused these news stories to come out and caused us to think twice about prescribing them. And if you're looking for a nice review, Pharmacotherapy in 2007 had a nice review on the atypicals versus Haldol for the treatment of delirium in acutely ill patients, and these were, again, non-ICU patients. So I think one of the reasons why delirium is so difficult to manage, and I don't expect you to read this slide, it was just put up there to illustrate my point, is that the etiology is so multifactorial and the pathophysiology is still not completely understood. But I found this wonderful article by Maldonado where he does attempt to put it all together. This also comes from his article that was published in Critical Care in 2008, where he was comparing kind of the neurochemical mechanisms associated with various delirium types. And this is kind of a chart that he put together to illustrate where we're kind of at as far as studies. And so, of course, similar to what we've already known, you see cholinergic deficiency, increased glutamate, and increased cytokine activity. And this is all part of the neurotransmitter model of delirium. And then this last one actually caught my eye, and it's so small, but it's there, that melatonin is decreased in agitated delirium. And the reason why this one caught my eye is because as I've been practicing out in the community, what I've seen is a lot of patients with agitated delirium started on melatonin, and I don't know if you guys have seen this, but I was just wondering, I don't know who's starting the patients on it, but I was wondering if there's any evidence to back it up. And lo and behold, there is a study. Melatonin decreases delirium in elderly patients. It's a randomized placebo-controlled trial in International Journal of Geriatric Psychiatry, published in 2010. So it's a Canadian study, and I find that the Canadian studies and the non-American studies actually really like to use these more naturopathic remedies, and they do quite a few studies in them. So this one, though, is new to me. And it's a small study and maybe not as newsworthy as I've made it, but it did catch my eye. So it's and again, it's a randomized, double-blind, placebo-controlled trial. And we all know how hard those are to fund and to do. It's relatively small. It's 145 patients, and they were all 65 years old or older, and they were randomized to receive either 0.5 milligrams of melatonin or placebo every night, times 14 days or until discharge. And the primary outcome was the occurrence of delirium as determined by the confusion assessment method. So the primary and secondary outcomes and adverse outcomes by treatment group are listed here. But what I did highlight is that delirium, again assessed by CAM, was lower in the melatonin group, so 7 patients, 12% of their population. And then incident delirium, so this is now the numbers excluding delirium that was actually present on their first measurement using the CAM in these patients, was also lower, so 3.6% in the melatonin group versus 19.2% in the placebo group, and both p-values were significant. So should we be using melatonin? I don't know, but some of my patients are already started on it. So I think, as we all know, prevention really is truly the best treatment for delirium because it's something that's just so difficult to treat. So one of the programs that Dr. Sharon Inoue developed is this Hospital Elder Life Program. I don't know how many of you have heard of it. It's been kind of disseminated now to various institutions and various hospitals throughout the U.S. She has a website. It's the hospitalalderlifeprogram.org. She meets with people who have started the program annually at the American Geriatric Society meetings, and I suspect at other meetings that you may attend as well. And before, you actually had to buy some of the rights to the program, which she felt, I believe, after many years, was actually becoming a barrier to other institutions adopting this program. So now it's free if you go to the website. So the program was developed, again, based on a successful multi-component intervention study conducted by the Yale Delirium Prevention Trial, again conducted by Dr. Inoue. And this was published in the New England Journal of Medicine in 1999, so it's over 10 years old. And what it demonstrated was a significant reduction in the development of delirium, so 9.9% of intervention patients versus 15% of usual care patients. You can see the odd ratio and the significant p-value there. And what the intervention involved is really a lot of volunteer work and less pharmacological intervention and more kind of logical day-to-day interventions. So frequent orientation, patients would have a whiteboard in their room. They always wrote the day, the month, the year, the patient's nurse, the patient's doctor, and patients were, again, frequently oriented. If they had any hearing aids or glasses, volunteers made sure that those were always on and turned on. If patients had difficulty going to sleep, they were actually given hand massages or back massages and warm drinks, soothing tea, played relaxing music instead of given, say what I normally give them, like trazodone or Ambien. And again, this idea of early mobilization where they were really encouraged to get up out of bed. Volunteers would walk them if they could walk, and really even just sit with them doing activities, crosswords, puzzles, whatever, really kind of keeping them awake during the day. They minimized nighttime disturbance by creating at least 8 hours of uninterrupted sleep. So again, really non-pharmacologic interventions that relied a lot on volunteers and nursing staff to implement. But what I found was I review articles for the Journal of American Geriatric Society, and one of the articles that came across my desk was the sustainability and scalability of the Hospital Elder Life Program at a community hospital. What I find interesting about this is the help model is, you should really visit the website, but it actually involves quite a lot of volunteer time, of people getting excited about delirium prevention and really taking the lead on a program, having institutional buy-in and really getting the program up and running. And it does involve extra FTEs for several members of a team that you would create. And so it's not free by any means. It's not necessarily cheap to start up. But what this study found is that they actually started the HELP program at a community hospital, and I believe this was in Philadelphia. It was a 500-bed teaching hospital out in the community. And they've been able to sustain this program for over 7 years. And what I liked about this study is that it started small, so they expanded it from 1 unit to the entire hospital. So they're serving over 7,000 patients annually with this HELP program. And the outcomes that they found, and they've really done, I think, quite a bit of measurement to prove that this program was something that they should continue, is that they found a lower rate of incident delirium, shorter length of stay, greater patient, family, and nursing staff satisfaction. Who doesn't want that? And cost savings for the hospital. And so what I also found interesting about this article is they actually got this hospital auditor who was very aggressive and almost like a tax auditor that you don't want looking at your records. And they really kind of dug up all the costs on the HELP program to see if this actually is a cost-saving program, and if managing delirium or preventing delirium with the HELP program saves the hospital money. And this is one of the reasons why the hospital allowed them to expand it to all the units, because like I said, again, it is costly to start up, is that they actually ended up saving about $7 million a year. So this is now 7 years out in the program, and they've built up to this savings of $7 million per year. And so the program is sustainable, I think, is the message, and hopefully will be disseminated to other places in the country. So I'm kind of winding up here, but back to the original NPR case story. Luckily for the Heltons, Dr. Sharon Inoue was actually working at the Boston Hospital where Mr. Helton was a patient, and she recognized that he was on an anti-seizure medication that could cause confusion. So she stopped the medication, took a few days for the drug to clear his system, and the delirium resolved. However, if you think delirium is an easy problem to solve, which hopefully you don't after this talk, this is Dr. Inoue actually talking about an experience she had when her father, who was also a physician who's now passed away, became ill and was hospitalized. So she says, "My father wound up getting delirious even when I was there at his bedside. I'm an expert in delirium, and I couldn't prevent it from happening. There were just so many physicians taking care of my father, so many medications. It was really hard for me to keep track of everything. I knew there were certain medications he couldn't tolerate, and I told one group of physicians, and then another group of physicians would prescribe it. And so it really just was quite eye-opening for me." And I found this kind of sad because as an expert in delirium, which, as psychiatrists, you all are as well, she couldn't prevent delirium in her own family member and couldn't prevent, all these things that she had studied and put in place herself in a hospital that she worked at. So in summary, I'd say delirium is a very costly problem, financially, socially, mentally, and emotionally. And hopefully I've presented some articles that will help motivate all of us to implement programs, improvements, and changes in our own institutions, and to move forward with recognizing, managing, and preventing this costly problem. So thank you all for listening. Any questions?
You mentioned the melatonin findings. How effective do you think it's been in your? Do you see it a lot? Do you try using it?
Yeah, I've only seen it in a couple of patients, and I kind of saw it and scoffed and was like, "What is this?" But I also, I think that if it's a good treatment, it has. There have been a couple of studies as far as its efficacy in insomnia, and those have all been promising. And the side effect profile appears to be currently, again, this is not FDA approved, etc., because it is a supplement, appears to be relatively benign. So if it's something that I can conceivably use in maybe patients that other treatments have not worked in, I think I might actually consider using it. But the patients I've seen on it are on, they're on 3 milligrams, and this study was done on 0.5 milligrams. And so it's really hard to tell, I think, these days with supplements, and we really need bigger, better studies. But I was just impressed that they were able to conduct a randomized controlled trial, which is, kind of difficult these days, especially in demented, agitated populations, because they're almost becoming sort of a protected population.
And the study was for prevention, right? It wasn't.
Exactly, it was for prevention, yeah.
So here at Harborview, we often use IV Haldol for treatment for delirium, both I think in part for cost as well as sometimes for delivery due to patients not having PO status. And I was just wondering, yet at the same time, I've reviewed the same literature that you've shown up here regarding atypicals versus typicals. Do you ever use IV Haldol? You know what I mean?
Oh, yeah. Oh, absolutely. I think when I get the call about an agitated patient and I'm there at the bedside and I see that they're pretty out of control, I really reach for the IV Haldol because it's so fast acting. And then I think, I don't know if you guys do something similar, but then I reach for something a bit less shorter acting, like the quetiapine or the risperidone, and start them on that. Oh, and I should mention one other thing. I work at a lot of skilled nursing facilities, and I've heard that, oftentimes when agitated patients transfer from the hospital to skilled nursing facilities, there's a lot of confusion around what you can have them on as far as antipsychotics and what the rules are. And basically, any type of, specifically Haldol, PRN, Ativan PRN is okay, which is unfortunate because a lot of times the patients come on Ativan PRN because that's the only thing that's acceptable in the nursing home. But IV Haldol, Haldol in any form, PRN, is not accepted in the nursing facility because it's considered a restraint. It's the same reasons why we're not allowed to have bed rails up in the nursing facility. It's considered a restraint. But if they're on scheduled doses of Haldol or any of the atypicals, that's acceptable. And what I find is a lot of the patients come on these scheduled regimens, but there's no instructions to taper. And I personally know to taper it, but I think a lot of the community physicians who aren't geriatricians, who aren't psychiatrists, who see their patient like once a month, don't know necessarily to taper them. So if you have patients that you want to eventually taper off of their antipsychotic because you expect their delirium to clear, please feel free to write that in the discharge notes or even on the order that please taper as appropriate as agitation resolves. But yeah, it's perfectly acceptable to discharge a patient who has been really hard to control on Haldol, on any of the atypicals, as long as they're scheduled. So no PRNs. Again, Ativan PRN for some reason is okay, but not Haldol. Any other questions?
Can you go to your website?
Oh, sorry, yes. So they have that program at Yale, but really not at any of the other hospitals that I've worked for. I think it's really difficult to get things like that started because, again, like I said, it requires a lot of upfront investment. You actually have to hire people. So if you go to the website, it actually lists the positions and how many FTEs each position requires. And there have been actually a lot of studies that I've reviewed as well that are kind of like help light programs. But Dr. Inoue has always responded to those articles that there's no such thing as help light. You have to actually go through the whole program because it's more sustainable and that because there's more investment, I think that it is more sustainable because people have invested more into it, so they try to keep it alive. So the question I have up here is from John at Harborview Medical Center, and says, patients are often given a diagnosis of hypoactive delirium. How can this be separated from encephalopathy from a medical condition which seems to be more common? Excellent question. I don't know if I have a really great answer to that. again, the go-to tools that I use are usually the confusion assessment method, and I refer back again to the DSM-4 criteria, and I really look at it that way. And what I tend to do is actually treat any medical conditions that I could possibly see affecting the patient, and cross my fingers and hope that that's the ticket to clearing either the encephalopathy from the medical condition, and if that doesn't work, then I move on to really just possibly diagnosing them with delirium and going from there. But I feel like those two things, encephalopathy from a medical condition and hypoactive delirium, are often the same and go hand in hand. And I'm not sure if I answered that question adequately. Any other questions? Okay. I didn't think so, because you guys really are the experts in delirium, and again, we're really excited, I think, as geriatricians to work with you to manage delirium. It's a very, I think, multidisciplinary and interdisciplinary problem. So please feel free to email me. Again, I'm at Northwest Hospital, and if anybody has any connections there, we are interested in starting a delirium prevention program, but it's one of those things that just takes a lot of buy-in and a lot of time, so we're moving slowly. Thank you.